Hello and welcome to Mechanical Ventilation Modes. My name is David Woodruff and I am the editor of Critical Care Nursing, made incredibly easy. I hope to make this incredibly easy for you too. Today we're going to talk a little bit about mechanical ventilation modes. This is the second in our series on mechanical ventilation. So let's review some of the terminology that's used with mechanical ventilation. First of all, we've seen this diagram before in the first part of this series, and we talk about the volume that we're breathing in and out all the time as being the tidal volume. That's that narrow band across the middle. Notice that if you take a deep breath in, that there's a huge inspiratory reserve. This additional area so that you can be able to go out and exercise and run and so on and so forth. And you have that inspiratory reserve so you can move more air. We also have the expiratory reserve, so down below the tidal volume. That's an area that you don't usually blow out, so if you were to blow the air out of your lungs and really force it out, you're forcing out the expiratory reserve. There is now yet another area called the residual volume all the way down at the bottom, and this is air that we cannot push out of our lungs, the residual volume. That's what's holding the alveoli open. One of the modes that we had talked about previously as it relates to how these work is called CPAP. And CPAP increases that residual volume down at the bottom. So the amount of air that is sitting there in the alveoli. So we put the patient on CPAP, we open those up a little bit more, those alveoli, and then we get better gas exchange. So CPAP will help the patient to increase their oxygenation. On the other hand, BiPAP does what CPAP does, so you see it down there at the bottom again in the residual volume, increasing residual volume. At the same time, it's also increasing our tidal volume by having a little bit of a positive pressure during inspiration. The positive inspiratory pressure is going to help that person to take a deeper breath with the same amount of effort. So the same amount of effort is being used here, and yet we have a deeper breath than we normally would in the tidal volume. So BiPAP not only increases the residual volume and therefore increases oxygenation, it also increases tidal volume, which is going to help to blow off CO2 and decrease the CO2 level. One of the most common types of mechanical ventilation that's used is called assist control. And in assist control, every breath is supported by the ventilator, whether it's a spontaneous breath or a machine-initiated breath. To clarify, a spontaneous breath is what you're doing right now. However, if we were to give you some anesthesia so that you were not breathing on your own, then we would need the machine to initiate breaths for you. So the difference between these is that a machine-initiated breath is the breath that we program into the ventilator telling it, hey, let's go ahead and give a breath, as opposed to the spontaneous breath, which the patient could just take on their own. Regardless of how the breath is initiated, in assist control, all of the breaths get the full volume. So the thing that's different about assist control is the volume is constant, but the pressure changes. The volume is constant, but the pressure changes. And in fact, sometimes that pressure gets to be pretty high, and we can end up with barotrauma. The other situation we could end up with is if the patient's taking a lot of spontaneous breaths, because those spontaneous breaths get the full tidal volume that our machine is set to, the patient could potentially have hyperventilation as well. Another option is intermittent mandatory ventilation, and most of these now are synchronized, so it's called SIMV, synchronized intermittent mandatory ventilation. In SIMV, this is one of the modes that we would use frequently for patients as an initial weaning mode. If our patient has spontaneous breaths on their own, oftentimes we will use SIMV as their support. Now, we may program that ventilator to give maybe, say, 10 breaths a minute. So it's going to give 10 breaths a minute. If that person breathes 18 times a minute, the machine's only going to give 10 of those. The other 8 breaths are going to be whatever the patient can pull in themselves. So what you can see is that the volumes vary between machine-initiated breaths and spontaneous breaths. Machine-initiated, full volume, spontaneous breaths, it's just whatever the person can pull in themselves. If they can pull in that full tidal volume, which is probably not likely, but if they can pull in its full tidal volume, then it would be the same. In most cases, our volume curve is going to look like this, where we've got little breaths that are spontaneous, and the big breaths are the machine-initiated. So it allows for some patient effort and minimizes barotrauma because the overall pressure inside the chest will be less. CPAP and PEEP, we already looked at what they do in our diagram there of our different volumes. But we use CPAP to try to prevent alveolar collapse. If the patient is spontaneously breathing, we call it CPAP. If the patient is on the ventilator, we call it PEEP. PEEP is positive end expiratory pressure. CPAP is continuous positive airway pressure. And that's what the terms mean. But it's the same process, that it's increasing our residual volume. So again, it's going to increase the patient's oxygenation without having to increase the FiO2. That would be nice, because if we increase FiO2, we can get to a point where we have oxygen toxicity. So maybe you've heard of that before, oxygen toxicity. What happens with oxygen toxicity is that when a patient is ill and they have an inflammatory process going on in their body, additional oxygen is turned into things called oxygen-free radicals, and we don't want to do that. So if we can keep the FiO2 down as low as possible and still increase our PO2, that would be very helpful, and we do that by using PEEP, or if the spontaneously breathing patient, we would use CPAP. Normally, we start fairly low, maybe with a pressure of about 5 centimeters of water. In patients who are on the ventilator with a low tidal volume strategy, we might move that up to maybe 8 to 12 centimeters of water of PEEP. Oftentimes, in our patients who have ARDS, we may move that PEEP up quite a bit higher, maybe starting in the area of about 16 to 20. We don't want to get too crazy, though, above 20, and we're really going to start to see some shunting of blood around our alveoli and not having good oxygenation. Some of the adverse effects, of course, there's respiratory adverse effects of PEEP, such as having barotrauma. There's hemodynamic adverse effects of PEEP, such as having an increased pressure in the thorax, which decreases our venous return to the heart. Pressure support is something else you may hear about. Pressure support is something we plug into the ventilator that just helps the patient overcome the resistance of the tubing. Breathing through ventilator tubing is similar to trying to breathe through a straw. So if you were to take a straw and just put it in your mouth and breathe through that straw while you walk up a couple flights of stairs, you're going to find that it gets really difficult to breathe, because that straw limits the amount of air that's going in and out. There's a lot of resistance in that narrow tubing, right? And the same thing is true with our ventilator tubing. Our ventilator tubing is going to provide resistance to that patient's being able to breathe. So we put the patient on pressure support. Pressure support is just a low amount, maybe 5 centimeters of water, continuous pressure that helps to overcome the resistance of the tubing. We'll also use it in many cases when a patient is weaning. We'll put them on pressure support and just turn off the ventilator. Now they're breathing spontaneously on their own, but we're using the pressure support to simulate what it'll be like when they're off the ventilator and they don't have to breathe through all that tubing. One other thing that you may hear something about is volume control versus pressure control ventilation. Volume control and pressure control ventilation differ in the end value that we are setting the ventilator up with. In volume control ventilation, that's the one that probably most people are most familiar with. This is a very common type of mechanical ventilation that we use. We set the ventilator for a volume. So we say we want that patient to receive 650 milliliters of air, and it blows that in, and then that's it. Okay, so it blows that air in at that volume, and the volume is constant. From one breath to the next, the pressure, though, will change. So one breath may have a low pressure, the next breath maybe has a higher pressure, especially if the patient starts to squirm or move or something like that. And it can end up causing high pressure in the patient's thorax. With pressure control ventilation, now we change the end point from being volume, we're going to push in 650 milliliters, now we're changing it to pressure. We say, okay, well, we're going to keep the pressure constant so that we're not achieving high pressures in the patient's thorax. However, from one breath to the next, the volume's going to change. And the volume may be inadequate in some cases on pressure control. Another option would be, let's use pressure-regulated volume control. So the volume is delivered at a preset pressure. Well, how could that be? We just said that with volume control, pressure changes. With pressure control, volume changes. So how can we have both volume and pressure remain constant? The thing we change with pressure-regulated volume control is time. Let's take a look at what these look like. The top line here is showing what happens with pressure control ventilation. So you see that the volume is remaining constant. So this is a volume curve here. The volume is remaining constant from one breath to the next. However, look at the red line underneath. The pressure is changing from one breath to another. The first one is kind of in the middle. The second one is below the midline. The third one, it's above the midline. Okay, so the pressure is changing. In pressure control ventilation, that's the graph at the bottom, you'll notice that the pressure remains constant. Each pressure curve is the same, but look at the volume curves. One is taller, one is smaller, one is all the way up to the top. So the volume is changing with each breath. And then we also mentioned pressure-regulated volume control. So how can both of these things remain constant? Now look at the volume curves, and you'll notice especially the middle one. The middle one is very compressed. So assuming that this is a strip that is being run off in time, you'll notice that the first and the third breath are taking more time than the second breath is. So what changes in pressure-regulated volume control is the amount of time that the breath is delivered. So some takeaways. Mechanical ventilation changes the airflow in the lungs. This is not the normal way of breathing. The large airways will receive more air, and there'll be less airflow to the alveoli. Because we're changing the way that the airflow goes in the lungs, we also change the intrathoracic pressure. Positive pressure in the lungs changes our gas exchange and our hemodynamics and can lead to barotrauma. By limiting our volume and pressure, we can reduce barotrauma and improve our gas exchange, and that's why pressure control ventilation and pressure-regulated volume control ventilation are such popular alternatives. Thank you for joining me for Mechanical Ventilation Modes. My name is David Woodruff, and until next time,